So good evening, everybody, and thank you for joining. So we'll be starting off right now. So this is Nurse Adekola. I'm a nurse by profession, and I've been an ECG instructor for a couple of years now, and I've been engaged in ECG training. I understand fully well that ECG is a crucial part of clinical practice. I also know that a lot of professionals struggle to get their head around the concept of ECG. So, and that is why we are here today. And that is why I believe every one of you have joined us. So thank you all for joining. It's good to have you with us. I can tell you that you are in the right place. I'm not going to promise you that after this training, then you start performing at expert level or you start interpreting ECG as it were, but you're going to have a good understanding, a good knowledge. You'll be able to make sense out of the ECGs that you've been seeing around. And I have a particular way of teaching this, which is quite simple, and I believe it's going to really help you. So I just need your concentration, and I need you to stay tuned and stay with me. There are a lot of ambiguity that surrounds ECG, but for the benefit of this teaching, I'll try as much as possible to limit you to the key things that you really, really need to know. So this teaching is going to be on the need to know basis. Okay, so what exactly you need to know? Like I said, there are a lot of chemistries, a lot of physics, a lot of physiologies around ECG, or you call it EKG, depending on where you are joining us from. But I'll try as much as possible to streamline it to what exactly you need to know. So if I can ask you in the comment section to let me know where you are joining us from and your profession specifically, then that's probably going to influence how I go about this teaching to make sure everybody gets value for their time. So if you can let me know in the comment section where you are joining us from and your profession specifically. So I have just themed this ECG as simple as ABC. I know that sounds a bit it's not as simple as ABC, but at the end of this section, you're going to realize it's not as difficult as you think. One more thing I need to tell us again is, because ECG is a broad subject, so I've decided to offer this over a couple of times. So throughout the month of May, I'll be coming up live on YouTube to teach on this. Okay. I'm anticipating probably about 6 or 7 sections. Yes. I don't want it to be longer than that, but I'm afraid I don't think it could be any less. Okay. So it's not just today that you're going to learn everything, except you are ready to stay with me for maybe 12 hours. Except you are ready to be here for 12 hours. Okay, but I'll make sure your time counts at every section. So that's something for you to look forward to. It's going to be a continuous it's going to be like a series. So this is just going to be the introductory part. I will let you know when the next section will be coming up. So if at any point you have any question or you need clarification, you can always put that in the comments section. I believe I'm audible, just to rule out any technical hitch. I don't want to be talking to myself. So it will be great if you can just confirm in the chat box that you're actually hearing me and I'm audible. So that would be great. That would be great. So learning outcomes for this section. I'll be talking you through the electrophysiology of the heart. And like I did mention earlier, the electrophysiology in itself is very wide, but I'm just going to try as much as possible to streamline it to what you need to know. And I'll do that in a concise and a simple way for you. Definitions, indications, and types of ECG, ECG directions, components of ECG, QRS transitions, ECG leads and electrodes, clinical scopes of ECG leads. This looks like a lot. I seem to be probably too optimistic with this, okay, because I'm afraid I'm not going to cover this in the next 1 hour or the next 1.5 hours. But wherever we stop today, then we pick it up from there in our next section. Right. ECG, as you might have known, it has to do with electrical transmission. It has to do with electrical activities going on in the heart. Okay, so there are few physiologies that you need to know. I'm not going to start talking about the anatomy and physiology of the heart now. So I believe if you are connected here, you should have a background understanding of that, or a basic understanding of that already. However, there are some peculiar characteristics of cardiac muscle tissues now. There are some attributes that are specific to cardiac muscles, and this influence the interpretation of ECG, the understanding of ECG. There are 4 of them. So we've got automaticity, excitability, contractility, and conductivity. Okay, so automaticity means ability of the cells to spontaneously initiate an impulse without any external stimulation. What this means is every component of the cardiac muscle tissues, muscle cells, they are capable of generating initiatives on their own. They are capable of generating impulses independently. Okay, so whatever the situation is, every part of the muscle tissues have the ability to intrinsically generate impulse on their own, and that is automaticity. So they are not just reliant on a particular section of the muscle tissue, if that makes sense. But you understand that when we talk about the activation of the cardiac cells. Okay, but that is what automaticity means. It means they can spontaneously initiate impulse on their own. Excitability, all the cardiac muscle tissues, they have the ability to respond to impulses, to stimuluses. Okay. They can respond to electrical stimulus, they can respond to chemical stimulus. They are excitable. Okay, they are excitable. So when you stimulate them, they respond, if that makes sense. Okay. Conductivity, that's the ability of the cells to transmit electrical impulse to another cardiac cell or from the point of stimulation throughout the entire muscle. So if the stimulation occurs in a particular part of the, just in a particular spot on the muscle, they have the ability to transmit that impulse throughout the entire muscle. That's conductivity. They can transfer that impulse from one part of the cell to the other as well. So they've got that intrinsic ability as well. And the last peculiar characteristics of this group of tissues is contractility. So as the name implies, they can contract following stimulation. So they have the ability to contract after receiving stimulus. Automaticity, excitability, conductivity, and contractility. I hope that is simple enough. You're going to be understanding the implications of all these characteristics as we move on in the training. So it's just providing a background understanding for you. Okay. So if EKG or ECG, we believe it has to do with electrical conduction, it has to do with electrical transmission, measuring the electrical activities of the heart. You cannot be talking about electrical transmission without talking about the wiring system. So the wiring system of the heart now, that's the conducting system. But before I go into that, I just want to mention to you about activations of the heart. There are two key principles that surrounds activation of the heart. Okay, we have what we call the rapid activation and sequential activation. Rapid activation, sequential activation. Rapid activation means we want as much myocardium to be contracting, as much myocardium as possible to be contracting or responding to stimulus. So myocardium, just for the record, as the cardiac muscles now. Okay, so we want as much of these cardiac muscles to be responding, to be contracting as possible. So as many of them to be contracting, as a rapid activation. When you talk about sequential activation, so even though we want many of them to be contracting, even though we want as many of the myocardiums to be responding, there needs to be a sequence. Okay, there needs to be a sequence. So the atria contracting first before the ventricles. So they need to maintain that order. Okay, so to ensure this order, that's what the conducting system of the heart is there for. That's what the conducting system of the heart is there for. Okay. So conducting system of the heart, these are specialized muscle cells and conducting fibers that initiate and conduct impulses rapidly through the heart. Maybe I should have put rapidly and sequentially, just to incorporate the two forms of activation that I described earlier. So these are specialized muscle cells and conducting fibers that initiate and conduct impulses rapidly and sequentially through the heart. It comprises of the SA node, the AV node, the bundle branches, you call them the bundle of East, then the Purkinje fibers. Okay, the SA node, that's the sinoatrial node. Sinoatrial node is considered to be natural pacemaker. It's considered to be natural pacemaker. I call them natural pacemaker because, like I mentioned when I was talking about the peculiar characteristics, when I was explaining the automaticity for us, every member of this team has the ability to initiate impulse. Okay, but it is primarily meant to be the assignment of SA node. Okay, and that's why I call them the natural pacemaker. So they are the natural pacemaker. The SA node is meant to be the natural. They're meant to take the lead. The SA node is meant to take the lead. It's meant to be natural pacemaker. But just in case SA node decides to go on strike, like in the UK now, we are in the season of strikes. So if SA node decides to go on strike for whatever reason, then every other member of the team, they have the ability to also generate impulse on their own without solely reliant on SA node. But SA node is the natural pacemaker. I hope that makes sense. So they initiate atrial depolarization, and this is located anteromedial in the anteromedial aspect of the superior vena cava in the right atrium. The impulse is conducted to the AV node through the internodal tract and Bachmann's bundle, then to the ventricles at the atrioventricular node. So from the SA node, the impulse is transmitted to the AV node. The AV node, at the AV node, there is a moment of delay, just a bit of delay, just maybe about 0.2 seconds of delay. And that delay is very important. I'm going to talk to us about the implication as we move on. But just to get this, I don't want to be going ahead of myself. So just to get this straightforward. So the SA node is a natural pacemaker. They initiate the atrial depolarization. For the sake of this teaching, anytime you hear me talk about depolarization, I want you to take it as contraction. Okay, just take it as contraction. And when you hear repolarization, then you can take that as a relaxation. Okay, so you can take depolarization as contraction, then repolarization, that's going back to your state of rest, repolarization as relaxation. So when I say atrial depolarization here, I mean atrial contraction. So the impulse spreads in a coordinated fashion throughout the ventricles via the bundle of East and then the Purkinje fibers. So this is what I'm talking. This is what I'm talking about here. If you can see my screen, so this is the SA node, just hiding by the entrance of the vena cava there, and this is the AV node right at this junction. So you can see the internodal tract is the one connecting the SA node to the AV node, and on this other side is the Bachmann's bundle. Because if you look at it, it will look as if the right atrium is isolated. The left atrium, it looks as if it's isolated, but there's actually Bachmann's bundle that transmits from the SA node to the right atrium, just to make sure it's also getting supplies. Okay, so From the AV node, then we have the bundle of ease, the ease bundle. This is the bundle of ease here. So we have the ease bundle just travel down, and that bifurcates. You can see the ease bundle split into two. So we have the right bundle and you have the left bundle branch. Okay, that's when maybe you've had it at some point. They're talking about bundle branch block. So they say right bundle branch block, left bundle branch block. This is actually what it means. So when there is any issue, or maybe there is a blockage here to the transmission of impulse, electrical transmission here, then this is right bundle branch block. Then just the same thing if it happens on the left side. So the bundle of is split into two, the right side and the left side. The left side further divides into two as well. So you have the left anterior and the left posterior, and they supply their respective surface of the ventricle. I hope I'm simple enough with that. So that's primarily what how the conducting system works. I told us there is a delay at the AV node. Okay, and it is this delay that shows in the ECG as the PR interval. Okay, it shows is the PR on the ECG, but we'll get to that at some point. There are some conditions where maybe for one reason or the other, the impulse seems to just bypass this AV node, and the delay is not showing. Okay, so maybe in the situation where we have maybe junctional redeems or ectopic redeems, okay, then sometimes it's just you see the PR interval getting shortened rather than getting shorter than what it's supposed to be. I'm trying to bring it as simple as possible. It's a bit difficult anyway. Okay, so this is just another pictorial representation of what exactly I've been talking about. So we have the SA node here, you have the AV node, then we have the bundle of is split into the right and the left. Then you have the Purkinje system, the Purkinje fibers. The edges. Yeah. So now electrocardiography itself. Sorry, just give me a minute. Electrocardiography is a non-invasive clinical procedure for measuring the electrical activities of the heart over a period of time using electrodes placed on the skin. So the amplitudes of the wave, they are measured, just plotted against time in milliseconds. So it's just like the regular x-axis and y-axis that we have in our high school. Okay, and amplitude, when you define amplitude in physics, you define amplitude as maximum displacement from an equilibrium. So literally what that means is the distance from the still position to the top of a crest, and maybe the bottom of a trough. If this is the still position, this is the equilibrium. So if there is an upward displacement, then you measure the amplitude to be the distance between this still position and the top of the crest, and that will be the amplitude, and vice versa. If the deflection is downward, if it's a downward deflection, then you are measuring your amplitude. That would be the distance from this still position, which is the equilibrium, to the bottom of the trough here. Okay, so that's primarily what we are doing in ECG. So you are just plotting your amplitude. You're plotting your amplitude on the y-axis, then you're plotting your time on the x-axis. So this is your y-axis. So your amplitude goes this way, and your time goes that way. So it's just a wave of ups and down, ups and down, ups and down. It's actually that. So in the next slide, you'll see what the ups and the downs actually represent. So forms of ECG. You have different forms of ECG. You have the standard 12-lead ECG, which is just the standard ECG. Conventionally, we use 10 electrodes to generate 12 leads, but you understand that as we go on. We have the 5 ECG cable system. We have the 3 ECG cable system. There is the ambulatory ones. The ambulatory ones can be for either continuous monitoring or event monitor. Continuous monitoring is just the one the patient just carries it around and monitors the patient continuously. Okay, the event monitor, the event ECG is also ambulatory, but in that situation, it's not recording 247, 24 hours a day. The instruction will be for the patient to just record anytime they feel symptoms. Anytime the patient feel maybe chest pain, for instance, then they can record whatever is going on at that point, because most times it's always acute, and by the time they even get to the hospital to see the doctor, probably it's already resolved. So, but with the event monitor, at that particular point of the at that particular point where when the patient was having the symptoms, then the patient will be able to record. So the clinician will have the understanding of what was going on at that particular moment. Then the stress ECG as well. Stress ECG is, you can just to see how the person can tolerate activity tolerance. Okay. In the case where patient is not ambulant, maybe you have a patient that is bedridden or that needs assistance. Obviously, you can't put the patient on the treadmill. Okay, so you can't put the patient on the treadmill for that. They actually use dobutamine in the past to challenge the heart. If you do dobutamine in the past to challenge the heart, and it gives the same response as it would have been if the patient was actually going through some physical exercise. So then the implantable ones as well. Okay. The implantable loop recorder is just a small device about the size of a maybe USB memory stick that's implanted under the skin. And sometimes it can record the heart's electrical activities for up to up to 2 to 3 years. Indications of ECG. Can I ask us to put in the comments section in your understanding of the indication of the ECG? Why do you like situations where you think ECG will be recommended, will be needed? So someone is telling me you're unable to use the chat box. I'm very sorry about that. I'm not sure I'll be able to resolve that right now without, let me see if I can resolve that. So I'm so sorry. I'm not sure if it's working. I'm not sure if it's working now. Okay, I think the chat box is working now. Yeah, I want to believe. Yeah. Okay, so just to save our time, I'll carry on with the indication. So there are a lot of indications, but I've just listed a couple of indications here. So the first thing here is post-successful cardiopulmonary resuscitation, acute coronary syndromes, acute chest pain following every cardiac surgery, or maybe cardiac pacing, acute heart failure, transfers to ITU, intensive care, requires ECG, chest pain. Okay, I can see people typing now, which is brilliant. During diagnostic or therapeutic procedures requiring conscious sedation or general anesthesia. So any procedure that requires conscious sedation or general anesthesia, then ECG is recommended. For drug overdose as well, ECG is recommended, especially if there is a risk of arrhythmia as part of the complication, then ECG is recommended. If a patient has suffered acute MI in the past, then ECG is also recommended. Then there are a couple of other indications. So if you know of any, then you can put in the chat box as well. The direction of ECG waves, as we might have noticed, the ECG itself is just a wave of upward and downward deflection, sometimes straight line, and you just wonder what this actually means. So the direction of the ECG wave depends on whether the electrical impulse is traveling towards or away from the electrode, from the detecting electrode. Okay, so if the electrical impulse is traveling directly towards the electrode, then that will produce a positive deflection. When I say positive deflection, I mean upward deflection. Okay, and when I say negative deflection, is the ones that is inverted. That's the negative deflection. Okay, so if an impulse is traveling towards the electrode, then it's going to give you, it's traveling towards the electrode, yeah, then it's going to give you a positive deflection. Okay, and if it's traveling away from the detecting electrode, from the particular electrode, then it's going to show up as a negative deflection. There are instances where you have it as maybe as right angle, or sometimes midway. It's maybe the electrode is somewhere here, then the impulse comes in and goes out again. Okay, so in that situation, the first part of the action will produce an initial upward deflection. Then if it goes out again, you have another downward deflection. So it depends on how close the impulse is to each on this continuum, on this particular continuum. That's what's going to affect the shape of the wave. So like if it's probably closer to this end, then it will be more positive. Then you have probably more positive and slightly negative, and vice versa. And sometimes it can be equiphasic, just like I illustrated there. So it can be, if it's midway, then it can be equivasic. So another key thing I want to tell us is the normal direction of cardiac transmission, cardiac impulse. I put it down as 450 on the time. Okay. Some people call it 5 o'clock, but to me, it's not really 5 o'clock. It's like, so if you have an imaginary clock here, then the normal direction of cardiac impulse is something like this. Okay, so and this is like 450 hour. So this is like 450 hour. So this is the normal direction of cardiac impulse. Okay. So if you have an electrode on this side, and you will agree with me, this is consistent with the anatomical shape of the heart as well. So this is consistent with the anatomical shape of the heart. So if you have an electrode on this side, maybe electrode A, yeah, and you place an electrode here as well, and you place another electrode here as C. So what's going to give us understanding of this is anything that is going on within these premises is going to show on the ECG wave as a negative deflection, because the impulse is actually traveling away from this. If you look at my arrow here, you look at this direction. So the impulse is actually traveling away from this electrode. So any activity that is going on this part of the heart is going to show up as a negative deflection. And if I want to ask us a tricky question now, from your understanding of the anatomy of the heart, if you can just picture the anatomy of the heart now, which part of the heart do you think this particular electrode A would be? Please put that in the chat box and let me just see what you think. Okay, so but while you are thinking about that, I've already established that any electrical activity going on here is going to come up as a negative deflection. and any activity going on with this Mr. B here, or let me move to Mr. C, who is so the electrical activity is coming towards C directly. Okay, so any activity going on here is going to show up as a positive deflection. It's going to show up as a positive deflection. Okay, and if you look at the structure of the heart, this looks to be consistent with the location of the left ventricle. Okay, and that's where we need the maximum impulse as well. Okay, so I'm just giving us a bit of head up there. Okay, so any activity going on this side is going to show up as a positive deflection. Any activity on this side is going to show up as a negative deflection. For the B, it's going to be biphasic, okay, because it looks like it comes in, then it goes out again. Okay, so from A to B is going to show as a positive deflection, then from B to C is going to show as a negative deflection. And that is how we make sense of all the ups and downs, all the ups and downs, all the ups and downs in the you see on the ECG. Okay. Anatomically now, my illustration here will be consistent with where you have the SA node, which is in the right atrium. Okay, just that right corner. So one sheet for the ECG is we have a lead. I'm going to mention that when I'm talking about the lead. We have a lead that shows directly the activities in this right atrium, and that lead is AVR. Okay, it's AVR. I'm going to show us what that means. But for the benefit of this section, one of the key things that you need to notice is that AVR in a normal ECG will always be negative. Okay, will always be negative, and the reason is just what I've explained to you, because the AVR is showing, sometimes they call it a cavitary lead. It shows the cavity of the right atria. That's primarily where the SA node is as well. So that's where the source of the impulse is meant to be. That's where the source of the impulse is. So, and the impulse, even though it's generated there, travels away from that place to the other part of the other part of the muscle cells. Excuse me. So because of that, any activity going on here will be shown as a negative deflection. That's why when you see AVR on any normal ECG, it will always be negative. Okay, that means every wave on AVR will be pointing downward. That's what I mean by being negative. Then by the time we're analyzing, we get to the leads and the electrode, then you understand that better. But my aim here is just to show us the direction of the ECG, how the impulses flow, and how that shows on the ECG. So you can see the upward and the downward deflection. Sometimes you see straight lines, the segments, you can see that as PR segments, you can see that as ST segments. It could be a moment of pause. Okay, it's just like maybe when there's no activity going on at that particular time, or maybe there's some refilling, maybe ventricular refilling or atrial refilling going on. Okay, but there's no contraction or anything going on, then it shows as an isoelectric line, a straight line. So you have a combination of upward deflections, downward deflections, and straight lines. So the combination of all these ups, down is what makes the ECG. I know it's a lot to take in. as we move on, I believe it's going to get more clearer for you. I'm not sure if anyone has got any question so far before I carry on. So if you have any question, please feel free to put in the chat box, then I can I can address that. And if you feel you need more understanding of the ECG, you can find my book on Amazon. Okay, I've had the opportunity of publishing a book on ECG, and it's very simple and concise. Okay, so it's synopsis, just summary of electrocardiography. So you can find it on Amazon. It's going to bless you. Trust me. So components of ECG. Components of ECG. I've been talking about ups, down, ups, down, ups, down for some time now, and you might be wondering what is up, what is down. Okay, so those are the components of the ECG. So the depolarization and repolarization of the heart is represented by the different waves. Okay, so the major waves in ECG, sometimes they name them to be 3, sometimes they split them up, but mainly you have the P wave, the QRS complex, and the T wave. Okay. The P wave represents the atrial depolarization. Let me do a quick knowledge check here. What does atrial depolarization mean? I think I've mentioned that some moments ago. Atrial depolarization, just a quick one. Anybody want to type for me what you mean by atrial depolarization? Okay, while you are doing that, okay, let me help you. I mentioned earlier that when you see depolarization, for the benefit of this training, just take it as contraction. Okay, just take it as contraction. So this is primarily atrial contraction. So atrial contraction is shown on the ECG as P waves. Is shown on the ECG as P waves. And the implication is anything that is going on with the atria, is going to show on the ECG. You're going to be seeing it with the P wave. Okay, so if there's any defects or any anomalies or any abnormalities with the P wave, then from today you can know that, okay, this directly relates to the atria. Okay, as we move on, then you will have understanding of there's a way you will know, okay, is it the right atrium or the left atrium? Okay, but I don't want to be, like I said, I don't want to be jumping ahead of myself. But for now, just take it as atrial depolarization is shown on the ECG as the P wave. So anything going on in the atria now is going to reflect on the P wave. So if you want to know maybe the atria is okay or not, then you check the P wave. I hope that makes sense. Then the QRS complex represents ventricular depolarization. That's ventricular contraction. Okay. They call it a complex rather than waves because it's like a combination of three different waves. So you have the Q, R, and S. So this represents ventricular depolarization. That's ventricular contraction. Okay. Another quick question here, which I want you to respond to. I know I've not mentioned it, but can you think of any reason why you think this QRS complex is taller than the P wave? Okay. Is there any reason why you think this is significantly taller than the P wave? So I need that. Let me just have your thoughts in the chat box. So while you are doing that, I'll carry on. So the QRS complex represents the ventricular depolarization. So just the same way, anything that is going on with the ventricles will show on the QRS complex. So when you are interpreting ECG, you can have a good understanding of what each aspect of the wave actually represents. Okay. So when you see them interpreting and they say, okay, it's got maybe ventricular hypertrophy, for example, they say, okay, it's got ventricular hypertrophy. How do they know it's ventricular hypertrophy and not atrial hypertrophy? Okay, so how are they able to separate what is going on with the ventricles and what is going on with the atria? So this is why you need this background understanding. So the QRS complex represents ventricular depolarization. Activity going on with the ventricles will be shown on this complex. I hope that is simple enough. I'm just trying to split the QRS now, so I'm not sure that's necessary anyway. So just to keep it on record, the Q wave is the initial negative deflection in the QRS in the ventricular depolarization. So you can see the Q wave here, just it's obvious. So that's the initial negative deflection. I've told us what negative deflection is and what positive deflection means. So this is the initial negative deflection in the QRS complex in the ventricular depolarization. That's the Q wave. The R wave is the positive deflection in the ventricular depolarization, and the S wave is the negative deflection after the R wave. So after the R wave, you have another negative deflection. So you have a negative deflection before and another one after the R wave. So we have T waves. T wave represents ventricular repolarization. T waves represents ventricular repolarization. Repolarization simply means contraction, relaxation, repolarization, just returning back to the state of rest. Okay, so it's a relaxation. So in my local adage, they say whatever goes up has to come down. So if there is a contraction, then there must be a relaxation. Okay, so if the ventricle contracts and we see that shown as the QRS complex, then the ventricle cannot remain persistently contracted. So it needs to relax. So when the ventricle relaxes, then it shows as the T wave. It shows as a T wave. So T wave represents ventricular repolarization. Another common question that used to come up is, okay, there is no wave representing atrial repolarization. There's no wave representing atrial repolarization. Why? It is simple. It's because the there's no wave representing atrial repolarization because atrial repolarization coincides with ventricular depolarization. Okay, so it's actually embedded somewhere here. So there's no separate wave to show, because I mentioned to us that whatever goes up must come down. So that does not mean the atria, they are persistently contracted. Okay, there is relaxation of the atrium, of the atria as well. But by the time the atria, by the time they are relaxing, that's the same time the ventricles are contracting. So it's that it coincides with ventricular depolarization, and that's why there is no separate wave to highlight atrial repolarization. But atrial repolarization does happen. Okay, it's just that it's embedded in the QRS complex. Okay, so the T wave is the ventricular repolarization. There is also U wave. U wave is not really common, but U wave is assumed to represent a repolarization of the interventricular septum and the papillary muscles. Okay, but it's not always obvious. It's only feasible in maybe there is hypothermia or hypokalemia. Then you can have a significantly obvious U wave. But when you see the U wave that is obvious, U wave is also another upward deflection, just a positive deflection after T. Okay, so when you have an ECG with you and the U wave is significant, is visible, is prominent, you have a prominent U wave, then that's probably hypokalemia right in front of you. I hope that makes sense. Let me see what. Okay. I asked the question why the QRS complex is taller than the P wave. Then someone says more effort is needed for the blood in the ventricles to pump out. Brilliant. Another person says more force to pump blood for systemic circulation. That's absolutely fantastic. You are bang on points. Okay, so there is greater impulses generated or needed for the ventricles to contract, because when the ventricles, they are contracting against a greater resistance, that's where the systemic circulation is coming from. Okay, compared to what you have in the atria. The atria, most times they just open up into the ventricles. So there is limited impulse generated, or there's limited force. Let me use the same words. There's limited resistance and limited force that you're pumping against. But for the ventricles, you're actually pumping against a major resistance. Because that's why the left ventricles, anatomically, they have larger muscle mass than the other part of the heart. Okay. Well, that's not for this section. Any questions so far, please? Okay, someone is asking, can I repeat the hyperkalemia point? I actually talked about hypokalemia. Is hypo I mentioned, and I said prominent U wave is seen in hypokalemia. So hypokalemia is most times characterized by prominent U wave. That was the point I made. When you see the U wave that is prominent in 8 of 10 patients, is hypokalemia. Hypothermia as well can show as a U wave can show in hypothermia as well. But in most cases, like 8 out of 10 times, is low potassium level that displays us, that makes the U wave to be quite prominent. Let me know if that answers your question. So we are gradually making sense out of the ECG now. Okay, so the next thing I really want to talk about is the QRS transition. You all know at this stage now, you know what the QRS represents, you know, that represents the ventricular contraction, the ventricular depolarization. So there is a pattern. There is a pattern for these QRS. There is a pattern that they follow on the ECG. Okay. Sorry, let me have a sip of water. So there is a pattern. So we call that QRS transition. What do I mean by that? The QRS complex we always start off to be negative. In lead one, we have, why I'm a bit skeptical is probably I could have just brought this up after maybe in the next session when I'm talking about the leads and electrodes. But since it's already here, I'm just going to talk around it, then I can always reiterate it in our next section. So we have leads V1 to V6 as the chest leads. Okay, so we have V1, V2, V3, V4, V5, and V6. Okay, so those are the chest or the precordial leads. So QRS complex, they are expected to start out negative in V1 and should end up positive in V6. Okay, the reason is simple, and that would still take me back to the initial explanation I was giving when I was talking about the direction of the ECG. The reason is because V1 is closer to the SA node, is closest to the SA node, okay, is closest to the source of the impulse, okay, and that impulse is traveling away from the SA node, from the right atrium down to the left ventricle. So if you still remember the direction I gave you the other time when I was talking about the 450 hour. Okay, so the V1 is the closest to the source of the impulse. So the impulse is moving away from that right atrium to the left ventricle, as it were. So the V1, V6, if this is I'm not sure I'm good at. Okay, so I'll say this is TT's art now. Okay, so V1, this is where you have the V1, you have the V2 like that, V3, V4, V5, and V6 across the chest. I'm going to show us how to correctly position the electrodes at the right time. But for the sake of this is this is just the shape where you have this the shape for the V1, V2 to V6. Okay, what that implies is V1, what I want to bring out here is V1 is the closest to the source of the impulse, which is the SA node, and V6 is the farthest. Okay, so it's going to start off negative. Then as the impulse is traveling towards the V6, then it's going to get more positive, more positive, more positive, more positive, more positive. Okay, so this is very significant in your understanding of ECG interpretation. Somewhere in between, there should be an equiphasic QRS complex, and that is referred to as the transition lead. Okay, that's referred to as the transition lead. If, let me say, this is our isoelectric line. So for V1, you can have something like this, probably very negative. Okay, for V2, you can have it more positive, still negative. Okay, then for V3, you can have it as equibasic. Then for V4, it's now going to be more positive, less negative, then like that. So the ratio will be will be changing. Okay, the ratio will be changing as it moves from V1 to V6. Okay. If you look at the image I've got on the screen, I'm not sure how bold it is from your hand, but if you can see it, just ignore this side for now. Okay, but if you can see this on the ECG paper, every ECG paper will label it for you as V1, V2, V3, V4, V5, and V6, and I believe you can see that on my screen. So if you look at this, this is a normal ECG. So if you look at this carefully, everything I'm explaining is displayed here. So you can see the V1, you can see the QRS complex here is more negative, almost extreme, almost totally negative. Then you can see the V2 is getting more positive, then V3 more positive, then V4 more positive, then you can see the V5 here more positive, then here until it looks like it's permanently totally negative in the V6. And that is the pattern, that's a normal pattern for, that's what we call the QRS transmission. That's a normal pattern that the QRS complexes should follow. Why you need this is because when you know what is normal, then it's easier for you to identify what is abnormal and when something is going wrong. Okay. Initially, I asked you to tell me your professions in the chat box. I didn't think anybody did. Okay, I think that was when the chat box was not opened anyway. But for instance, now I am a nurse. I'm not. I was talking to a colleague recently, and I said, okay, you really don't. I don't need you to be treating arrhythmia as it were, but I need you to be able to escalate. I need you to be able to identify that something is wrong with this patient. You may not even know that something in quotes. You may not know that something in quotes, but you should be able to know something is not right with this patient. Mere looking at the ECG, to make the matter worse, some of you work in ITU where your patient is connected to cardiac monitors consistently, and still you have your patient arresting right in front of you without anybody noticing it. In 85% of time, a patient that is going to arrest there will be this pre-arrest signs that you're going to see on the ECG. There will be some ECG changes that comes before it. And that is why you are there as a nurse. You can identify that and say, something is not going well with this particular patient. Just mere looking at the QRS transition or the pattern of the QRS, then you can raise your concern. Then they can do further investigation or probably refer to experts, maybe cardiologists and things like that. And by just identifying that, you might be saving a life. Okay, you might be saving a life, but just raising the concern, raising the awareness, escalating, something is not really right with you. How will you know something is not right? It's because you have the understanding of what is normal, and you know this is not what Nurse Adekola has mentioned to us to be the normal transition. So I know something is wrong here. Okay. Most often, the transition leads mostly occur in lead 4. In the image I've got on the screen, the transition lead seems to be in the V4, which is absolutely okay. So if you have not have a look at the book, everything I've been talking about, they're just tip of iceberg from my book. You get it more in depth from the book. You can scan the barcode you're seeing on your screen to get a copy of the book for yourself. You really need to have this. It doesn't matter if you're a nurse or you are a doctor or you are paramedics, as long as you deal with patients directly. you are involved in patient care, then I think you need to get this. So far now, we've been able to talk about the electrophysiology of the heart. I've walked us through the peculiar characteristics of the cardiac muscles. As when I was talking to us about the automaticity, I was telling us about the contractility, the conductility, and the excitability. Okay, if you are just joining us, those things are on record. Then you can always go back. You can always go back to them. I've explained to us as well the forms of ECGs, the indications, what ECG represents. I told us about the activations of the heart, the cardiac activations. That's where I was talking about the rapid activations and sequential activations, and as well discussed about the conducting system of the heart, how they organize themselves and make sure the impulses, they are coordinated, they are transmitted in a coordinated version. Okay, so if you have any question or any concern, then please do use the chat box and let me know if you have any concern. Just trying to recap now, we've talked about the ECG directions as well. That's where I was telling you when the impulse is moving towards the electrode, then it's going to show as a positive deflection, and that would be like upward deflection. And when it's moving away from, then it's going to show as a negative deflection. We've talked about the components of ECG as well. So at this point, I expect you to know what the P wave represents. I expect you to know what the QRS complex represents. I expect you to know what the T wave represents and the U wave as well. Okay. As we move forward in this series, I'm going to delve more deeper into the normal and the abnormalities, the normality and the abnormalities of each component. Okay, so the QRS complexes as well, separately, they still have their own specificities, and they have what they represent. Okay, so like the Q waves now, for example, when you see maybe a Q waves, a deep Q waves, then it can show an old MI. It can mean the patient has had probably an old MI, maybe ileal infarction or something. Okay, so they have their own clinical scopes as we move on in this training. Then the QRS transition have told us how it has to start negative from the V1 to the V6, and I've explained to us why that is. It's purely due to the direction of the impulse transmission. Okay. In our next section, I'm going to be talking to us about the ECG leads specifically and the electrodes, and covering their clinical scopes for us as well. Then we move on to how to conduct ECG is not really the main problem. I think averagely that's like the simplest part of it. The key part is making sense out of the printout. Okay, so making sense out of the printout is actually that's my main focus. Okay, but going forward, we'll be going deeper into that. So if you have any question, then you can drop it for me. I'm convinced this is a good time for us to put a pause to it. Okay, so if you are here and you still haven't subscribed to our channel, I don't know what you are waiting for. So use the subscribe button and subscribe, then click the notification bell as well. I'm sorry I can't give us a date now when the next section is going to be, but I'll definitely try my best to broadcast it, and it might help you if your notification bell is on, so you can get notified when the next section is on. So if after I'm still going to leave the recording on for a couple of days, so you can go through it. If after going through it you have questions, I'm more than happy to help you and support you. So you can drop your questions in the chat box at any time. I'm happy to help with that. Let me just have a look and be sure. Let me have a look and be sure there is no question here. Okay, someone is asking. I'll drop the link. I'm not sure I can do that now, but I'll drop the link for the purchase of the link directly in the chat box. I'll do that once I close this streaming. Yes, I should be able to do that in a bit. That's fine. So thank you all for joining. It's very nice to have you with us. Try and share the video to your colleagues. Don't be stingy. After all, it's free of charge. So don't be stingy. Share with your colleagues. Just in case your loved one find themselves under the care of your colleagues later, then you can be sure they'll be getting the best and quality care. So share with your colleagues and your friends. So I hope to see you again in my next series. Thank you all for coming. God bless you all. Bye.